Well, good evening, everyone, and welcome to the American Migraine Foundation's webinar on navigating insurance. The American Migraine Foundation is interested in addressing access to care for migraine patients with the goal of understanding the current barriers in during the migraine patient journey is related to access to care for new therapies for migraine prevention, as well as developing and aligning strategies to alleviate barriers to high-quality, patient-centered preventative medicine for migraine. So I am pleased to introduce our panel. We have two physicians, an adult headache specialist, a pediatric headache specialist, and patient advocate that will be introducing themselves more specifically. We'll start with Dr. Dougherty.
Hi, I'm Carrie Dougherty. I'm at MedStar Georgetown University Hospital. I'm a neurologist. I'm a neurologist and a headache specialist in Washington, D.C., and I'm delighted to be here.
Yeah, okay, Dr. Gelfand.
I'm Amy Gelfand. I'm a pediatric headache specialist at the University of California, San Francisco, and also very much happy to be here. Thank you.
And Ms. Rutherford.
Hi, I'm Angie Rutherford. Like many of you on the webinar today, I suffer from migraines. I've experienced them my entire life, essentially. And thankfully, though, since October of 2020, I have been in remission thanks to one of the CGRPs that are available to those of us with migraine.
Great. Well, are you ready to start your presentation?
I am. I think my slides are going to come up and we're going to talk about navigating insurance. I'm going to give the adult perspective and then Dr. Gelfand will follow because things are obviously different with pediatrics. So my goal today is to talk about navigating insurance. I want to give you tidbits for how to get what you need and try to stay sane in the process, which can be challenging. Next slide. So this is what I call the buzzkill of the prior authorization. So say you have migraine and you've had it for a very long time and you've seen new medications and you've heard buzz that there are new options available and you seek out care after maybe some time without either appropriate care or just struggling on your own. And you have a new provider who gives you a new plan that you're super excited about with new medications, and you leave the visit happy and excited about what you've got and what the new options are and the possibilities. And while you're checking out, you get a text on your phone from your pharmacy app that says, "We contacted your healthcare provider for verification." And you're like, okay, well, I guess that maybe there's something that was amiss in the prescription. It'll work itself out. And the next day you go back and check the app to say, what's the status? Can I go to the pharmacy and pick it up? And under the medication that was prescribed, it says on hold. And so you're stuck being like, now what? Maybe you call the physician to try to clarify. And no matter, or you go to the pharmacy and say, what do I need? And what you generally will find out is that the requirement that you're missing to be able to get your medication is a prior authorization. Next slide. So what is a prior authorization and who determines your need for a prior authorization? So one of the vocabulary lessons today is learning what a pharmacy benefit manager is. So all of us know that we have medical insurance. And then in addition to medical insurance, you may also have prescription drug coverage that is managed through a pharmacy benefit manager. And they're either dictated by your medical insurance or by your employer if it's self-insured. And they develop a formulary of preferred medications that they would like you to take. And if you would like things other than that, they're going to require you to jump through some hoops. And one of those hoops is the prior authorization, which is essentially a request from the provider for confirmation of coverage. And it can be for a medication or also for a procedure or imaging that says, yes, we will cover this medication or this procedure. And the provider has to submit information about why they're using it and context for what the reason is and what they used it for and what you may have tried in the past. Next slide. So how are prior authorizations completed? So one of the first rate limiting steps is that the provider or the provider's office needs to know that that your insurance, your PBM requires a prior authorization for any certain med. And sometimes we have a spidey sense that that's a possibility. When we're initially ordering the prescription in the electronic medical record, it will actually, in mine, it gives me like a color code that if it's green, I'm good to go. And if it's red, there's probably going to be some holdup. And in mine, if it's white, it means that there's probably slim to none chance that it would be covered unless you had really extenuating circumstances. That's not foolproof, and it really depends on the accuracy of my system with your insurance. The other is that we can get a direct notification from either the pharmacy or from the PBM saying that a prior authorization is required. I like to joke that oftentimes the pharmacy says they called us. They've never called us. Oftentimes it's a litany of faxes that come in to the office. There's also an intermediary step. Often prior authorizations are processed through what's called Cover My Meds, which is a website essentially that facilitates submission of these to different PBMs, and they can provide an alert. But there's also, a lot of duplicates that occur. I, in preparation for this webinar, signed on to my Cover My Meds account, which luckily my assistant normally manages. And I had 1,000 pending prior authorizations in the queue. Now, luckily, I don't have 1,000 patients that are waiting for med, but you can just see like what my assistant has to manage on a regular basis and what she has to filter through for what is accurate and what is inaccurate. So the other is oftentimes the easiest point from A to B is directly from the patient to say, I'm at the pharmacy, they require a prior authorization, can you initiate? And I tell patients all the time, send me a portal message as soon as you find that out and I will make it happen. So once we know, then the forms have to be obtained either through Cover My Meds or directly from the PBM, where we write down what we're using the medication for, what medication we want, how much we want of it, how many tabs per month. This is a big deal for patients with migraine. And then the context of what you've tried previously that either, didn't work or caused intolerable side effects, or you can't take because you have some other medical complication that means it's not safe for you. And then we send that information with the context of your clinic notes to your PBM, and they make a determination. And they, in the matter of sometimes 2 days, sometimes 10 business days, sometimes I don't know where it goes, and eventually it filters back, and we get a determination that says it's either approved, and then the pharmacy can rerun the prescription and fill the medication, or that it's denied, and then they should give context for why it's denied, which you can use to argue. Next slide. So I have here an example of the coverage criteria for perhaps Aimovig or Emgality. So I kind of abbreviated from one I found online, where in the context of using Emgality or Aimovig as a preventive for migraine, these are the criteria that the PBM sets. You have to have the diagnosis of migraine. So it can't be, for example, for a cluster headache or any other headache disorder. You have to have documented failure, either because you took the medication and it caused side effects, you took the medication for this pre-specified period of time, which they can be really nitpicky about, and it was not effective, or you can't take these medications because of some other comorbidity. And for this example, it was amitriptyline, a beta blocker, or topiramate. But it can be really specific that it has to be these medications. If you, for example, took candesartan in this context, it may not qualify. Or if you took duloxetine as a preventive, which has data, if you don't check the exact boxes that they specify, that will be a reason for a denial. The other is that they may preclude the situation in which you use it. So you can use Aimovig or Emgality, but it says in part 3, you can't use it in combination with another CGRP monoclonal antibody, and you can't use it in combination with the GPAN, which, if you know that one's a preventive and one's an acute, may be a conundrum for you. Next slide. So how do they determine this list? Well, somewhat arbitrarily, but theoretically based on FDA indication. So exactly how the medication was tested in a clinical trial for that indication, and that indication can be very specific, that it is episodic migraine or chronic migraine, but not the opposite. They often will include medical society guidelines. So the American Headache Society puts out guidelines and has put out 2 updates in recent past on the use of new medications in clinical practice that sometimes provide more context than just the clinical trial information. They also make a determination based on contracts with pharmaceutical companies. So they may have a deal that they prefer Ajovy, but that they don't prefer Aimovig or Emgality. And that contract can change year to year. So you could have gone through all the hoops of a prior authorization for a medication, say Aimovig, and it's working great for you in 2022. And then in 2023, the contracts change for the pharmaceutical benefit manager, and now they've made a deal with Ajovy, and Ajovy is preferred, and you have to switch and try Ajovy, and either it works for you and you're great, or it doesn't work for you, and then you can ask for Aimovig again. And that's obviously super duper frustrating. Next slide. So some of the reasons, we've touched on these. The reason prior authorization denied, you're not using it for the FDA labeled indication. I see this most commonly for right now GPANTs, like some of the preventive GPANTs, Nurtec and Qulipta right now are only FDA approved in episodic migraine. So in a patient population of chronic migraine, that can be a barrier. You didn't previously try the required alternatives, and that means the very specific required alternatives, like if you tried nortriptyline but not amitriptyline. If you plan to use in combination with another treatment, and they've specified that you can't do that, or if there's just a formulary exclusion and the policy says we will not cover that medication, period, which can be super challenging. Next slide. So your options. And my first 2 options, unfortunately, aren't really relevant for the newest medications available in migraine because there are not generic alternatives. But in the case of triptans, for example, it may be that a different generic is preferred. And oftentimes we get around quantity limits in certain cases by using discount pharmacy programs. I give 2 examples here, GoodRx or the Mark Cuban Cost Plus Pharmacy. The mainstay oftentimes to navigate some of this for a period of time is using the Pharma Copay Savings Program, which is the coupon that each pharmaceutical puts out with the associated medication. But they have lots of fine print. So you have to be using it for the FDA indication. It may only be good for 1 or 2 fills until there is an attempt at a prior authorization. And if the prior auth is denied, there may be a couple more fills they cover and then they don't. Or they may say, unless you have attempted the prior authorization or unless the prior authorization goes through, the coupon doesn't work. And sometimes it'll work for, a year, and then the terms of the coupon will change from year to year. So you really have to read the fine print. You have to be really pushy with the pharmacist to apply it. There are phone numbers on each of the cards that the pharmacist or you can contact if you feel like it's not going through or not working. And then there are financial assistance programs from each of the pharmaceutical companies that are based on income and can be anywhere between 3 and 5 times the federal poverty limits. But you have to fill out an application for that, which includes details about your income, and your provider often has to sign off on that as well. Next slide. So you do have an option to fight if a PA is denied. So the denial will specify why it was denied, and the patient can directly appeal with documentation. It will say in the language, oftentimes in some of the insurers in our area, it actually specifies that the patient has to be the person that files the appeal. It cannot be the provider. In some instances, it says the patient or their authorized representative. I will tell you that I think oftentimes the most effective appeals are initiated by the patient and not necessarily by the provider, because I'm considered a biased individual in terms of this fight. Sometimes it's just a matter of telling them that they didn't read the note. And this happens a lot, that you sent in all the right information and the documentation and you've tried X, Y, and Z and are using it for the approved indication, and they just weren't paying attention. Sometimes I think they're just waiting out to see how hard do you want to work for this? If you don't meet criteria, you need to give good context for what the mitigating circumstances are, why you should get this medication, even though you don't meet X, Y, or Z. You want to support your appeal with your clinic notes, and everyone should have access to their own clinic notes now that we have open access, either via the patient portal or directly from your provider. In some circumstances, it may be helpful if you have like an uncommon headache disorder to give information about a journal article, and your provider can oftentimes help you with that. to say there's a case series that used this medication just like me and it was effective. And then also a letter of medical necessity from your provider can also be used for support. Next slide. So my prescription here is advocacy. So really, in order to be effective at getting the medications that you need, you have to empower yourself with knowledge about your diagnosis, your medications, your medical history. Sometimes you can think we're really nitpicky in a visit to ask you the list of medications you've tried, because sometimes the requirements for a prior authorization, it can be as specific as what year, how many milligrams, and for how many months did you try it. And if I don't submit that, they will deny the medication. So, you know, saying I've tried everything, all there was, won't help me unless I really have specific details. You need to know your PBM. I can't tell you how many times in the office we ask a patient when we're initiating med, you know, what's your pharmacy benefit manager? And they hand me their insurance card. And I try to explain the difference between medical insurance and a pharmacy benefit manager. It can be super confusing, but you knowing can really help you find out what's on your formulary and what you need to know to get the medications. And then you have to be prepared to directly advocate either with your insurance, and I was like, the mistake here was that I should have written, or with your employer. If you have employee-sponsored insurance, it can be helpful to go to HR and say, I'm missing work, or my spouse is missing work because of migraine, and you have contracted with this company, and I'm not getting the medication I need that makes me better. And I've seen a lot of things that were very difficult for me to fight or for the patient to fight, you know, where HR got involved and made a difference. And then you can advocate on a state and national level. There are resources to appeal, both with consumer kind of advocacy groups within your state. And on the last page of this, which hopefully will be somewhere for you guys to access, there's the National Patient Advocacy Foundation actually has a curriculum on how to advocate. And you can also file a consumer complaint through your state, and the Headache and Migraine Policy Forum has information on that. And with that, I will turn it over to Dr. Gelfand, who's going to tell you how you do it when your patient population often doesn't meet the FDA indication.
Yeah, I would.
Thank you so much.
That was great. I would say that it's very much everything you said applies, though, for kids and adolescents as well. And as Dr. Dougherty was saying, that if you're under 18, a number of medications or biologics are going to be considered what's called off-label, meaning that they have not yet been given an indication for migraine in people who are under 18. And so very often insurance companies will deny coverage for patients in our pediatric headache program based on them not being 18. This happens 100 times a day. And it's very frustrating, especially when you step back and think about, well, what is FDA indicated for kids? There is one, migraine preventive, FDA labeled for 12 to 17-year-olds, Topiramate. Nothing's labeled for those under age 12. And there are 4 triptans labeled for 12 to 17-year-olds. One is labeled for down to age 6, that's rizatriptan. That's a very small armamentarium to try to treat migraine, especially difficult migraine in these age groups. And so whenever I'm faced with a what's called a peer-to-peer, when we're talking to another doctor on insurance company doctor, and they're saying it's not indicated, it's not FDA indicated for under 18, I tell them exactly how short the list is of indicated preventives for these age groups, and how that's really utter nonsense as a reason. But it is what it is. It's an imperfect system. And so very often these medications, especially the more advanced or more novel medications, will be denied for kids. And our program, we appeal all denials, and it's very time consuming, as you can imagine. We have staff that their entire work week is managing appeals and denials, and it's sometimes it just makes me want to cry when I think about like how much time could be going to patients and families, but instead is going to arguing with insurance companies. But it is what it is, and it's not how anybody would like to be spending their time. Everyone would rather be spending their time with their patients. So it's definitely a challenging situation. Appeals also require a lot of patience. They can take time. At least here in California, sometimes they'll take 14 to 30 business days. It's not a fast process, and even just thinking about business days for healthcare is always sort of maddening as well, because people are experiencing symptoms and disease on Saturdays and Sundays and holidays, but these things really move at a glacial pace. So that can be very frustrating. And then if the appeal doesn't overturn the denial, there is sometimes an opportunity, depends on the insurance plan and exactly, for the clinician to do what's called a peer-to-peer, which is where we get on the phone with the insurance company doctor and explain why it is that we think that the patient should have access to the treatment that we've prescribed. And I put the quotation marks there because it's never, in my mind, it's never actually a true peer. I've never spoken to another child neurologist. I've certainly never spoken to another headache specialist. It's very rare that I'm actually talking to a neurologist or even necessarily a pediatrician. So, we're not talking to people who have the same background or training, and it can be a bit of a difficult process there too. And sometimes their hands are a little bit tied where they can't necessarily move things forward. So, the next level after that, if a family wants to go to it, is basically taking the insurance company to the state insurance board and challenging the denial. And in that situation, and this really does come from the patient or family advocating, in that situation, they do usually bring in 3 specialists, ideally really child neurologists and headache specialists, who can say, whether they think that the treatment is indicated or not. And I have seen some of those be successful, but that's clearly a lot of work. And I realize that it's a very hard thing when you're already experiencing so much disability or from your child's disease and investing so much time in just trying to take care of them, that then to have to go and do all this extra advocacy is really sort of painful. But sometimes it is the thing that can make a difference. So, I was trying in preparing for this to think about what are some of the things that people can do, what are the proactive steps? Well, many of our patients are adolescents, and so if they're an older adolescent, if they're going to turn 18 soon, it is worth retrying. I have a lot of patients where we tried to get them access to something a year ago and we couldn't, but now they've turned 18, it's definitely worth retrying now that they're on label for the medication. So if your 18th birthday is coming up, have hope that maybe things will be a little bit different if we do that. I think that some of those companies that Dr. Dougherty was mentioning are great as well. I don't have any relationships with any of them for trying to get things that are less expensive. I recently learned that a medication called a Prepitant, or Amend is the trade name. It's an anti-nausea medication that I sometimes prescribe, and it can be very expensive, that they do have some of those for less money. So there are some workarounds sometimes through some other ways, but they still are going to involve out-of-pocket costs. And I think that advocacy is really the message here, that as hard as our team is working to try to get the appeals through, try to get the denials overturned, it's a slow process. And I do think that when we come at it from multiple angles, when it's, the clinician team is coming at it and the patient family team is coming at it, I think that is when it's most likely to be successful. So I think that if you can call your insurance company and try to also work at the denial from your end too, I think that's worthwhile. The other thing that I'll say, because a lot of times in pediatric headache, we're not just necessarily prescribing medication, we're recommending cognitive behavioral therapy, which is really strongly evidence-based treatment for chronic migraine in young people. But sometimes the behavioral health insurance benefits are quite different from the medical insurance health benefits on somebody's plan, and it can be tricky. Sometimes kids will come into our program and they can see me, they can see the neurologist, but they're not covered to see our psychologist because the way that their insurance treats behavioral health is different. And that's a whole other world of challenges. And it is really hard when the person has to go to some outside clinician. I mean, anything obviously is better than nothing, but one of the really nice advantages of when you can see the neurologist and the psychologist in the same program is we can talk to each other, and it's very integrated care. And so when these things get divided and put into different silos, we lose a lot. So that's a challenge. And some of when we are trying to prescribe medications, a lot of the things that Dr. Dougherty was saying, that you have to have 2 previous preventive trials of X, Y, and Z medications, things that are evidence-based in kids are not going to count. So they're not going to count cognitive behavioral therapy, even though you've gone and you've done, your 8 or 10 sessions, and that was the most evidence-based thing that you possibly could have done. That's not going to count towards those 2 preventive trials. They're not going to count devices. If you've tried the Cephally device, they're not going to count the supplements like riboflavin and magnesium and some of these other things that we might have used for very, very young people. So that's also a bit of a frustrating thing, that there is that very short list that the insurance company is going to recognize as a previous trial of a preventive or for an acute medicine. But and we're all on the same team. We're all trying to work it through with you. And I think just the more involved that you can be, the more likely things are to be successful. So I think that's the message, is really just trying to self-advocate as much as you possibly can, and working as a team with your clinicians, and knowing that we are advocating as hard as we can too.
Great, thank you. Guess we'll move on to Angie. Oh.
I think your mic is off. I think you're muted. Oh.
All right. Having some technical. Okay.
Yeah, I was muted and couldn't do it on my own. So, our MDs here on the webinar have, both of them have emphasized advocating for yourself, and I think that's a really key piece of navigating this insurance nightmare. I have been through it myself. Just a little bit of my background. So I have suffered from migraine my entire life. And I feel really fortunate to actually be dealing with migraine, in this day and age, because now we actually have medications that are developed specifically for migraine. And honestly, I didn't think that would ever happen in my lifetime. So I feel very fortunate that the opportunity is there to take medications that are actually developed for this instead of off-label uses. So a few years ago, my migraines had taken a turn for a worse, and not only was I experiencing the pain and aura and everything else, but I also started to experience vertigo. I was dealing with limb weakness. It's even now on my medical record that I suffered a migraine-related stroke, and just became very nightmarish. And fortunately, I went to a migraine specialist who prescribed one of the CGRPs, and I'm not going to name the specific medication because I don't want to sound like I'm, endorsing any one particular product, but I was very fortunate, and the one that was prescribed for me worked for me right off the bat. As a matter of fact, the day that I picked up the injection, I was in the midst of developing a migraine and took the injection, and it knocked it out. And for the next was like 6 to 7 months, I was migraine free. Till the end of the year, I was using the pharmaceutical company. They had a program where I could get the medication for free, but that ran out at the end of a calendar year. So then it came time for prior authorization. And unfortunately, the migraine medication that I was taking was not on the formulary, but the other two CGRPs were. And one I can't take, it was contraindicated for me, so I tried the other. Unfortunately, after 6 months, it was deemed a failure. My migraines had come back. I was very fortunate in that the prescription insurance, they relented very quickly and allowed me to go back to the medication that I was taking, and went back to that starting in October of 2020, and I have been migraine free again since then. There have been some issues though, and having heard from both of the doctors on the call, I understand a little bit more now why I've had some of the issues that I've had with prior authorizations. Hearing that, you know, they've gotten on to cover my meds and have, you know, 1,000 prior authorizations waiting in there. Now I understand why I've had some of the problems, but just in case some of you were at the beginning of this journey, some of the things that I've experienced, prior authorizations, despite the fact that they have been approved before, being rejected suddenly because paperwork was not filled out properly. You're not your doctor's only patient. They have many, many others. Healthcare is a very busy industry, and so mistakes are going to happen. Try to be as understanding of that as possible, and talk to that, you know, prescription insurer, because when I called them and said, why was this rejected? You guys have approved it, you know, the past 12 months. Why is this suddenly being rejected? Well, because this box was not checked and this box was not checked. Talked to my doctor's office. Sorry, we made a mistake. We kind of got you mixed up with somebody else. These things happened. You know, another thing that has happened to me before is that the prior authorization typically is going to be good for about 6 months. That's how it is for my prescription insurer. I have gotten notifications from them that they have attempted to reach my physician's office and they've not heard from them. And then the prior authorization expires and I go to fill my prescription and I've got to go back through those hoops again. One thing that I have now taken to doing is putting on my work calendar when my prior authorization is going to expire. And it's on my calendar to contact my doctor's office 30 days before that expiration happens. Somebody could be out sick. They might be on vacation. A lot of this is done by fax. We all know how reliable fax machines can be. Sometimes the fax doesn't come through to the insurer. Sometimes it doesn't even get to the doctor's office to begin with. There's just a lot of things that can happen. So that's one thing that I highly recommend. And then the other thing that I've had issues with is the coupon or savings program through the pharmaceutical company. And so far I've been very fortunate. They have not said, you're cut off, you've used this too many times. But one thing that has happened to me this past calendar year is that even though the coupon is good for 12 months, every single month when my pharmacy goes to fill my prescription, they get a notification that the coupon has expired, even though it's not supposed to expire until December 31st of the calendar year. Thankfully, my pharmacist is used to dealing with me in this prescription now, so when they do find that out, they have just gone in and immediately reapplied for the coupon for me. But there's also a concierge that you can call. There's normally going to be some kind of a 1-800, 188 number to call and talk to the pharmaceutical company to make sure that that coupon is still good. So those are just, you know, a couple of tips that I have that I've experienced. And another website that I came across recently myself would be helpful if you're going through that appeals process. Is something called coveragerights.org. And it has a map of the United States, and you can click on the particular state that you are in, and it will give you some information about, you know, exactly when and under what circumstances you should appeal at the state level, under what circumstances you cannot appeal. So I thought that was a very helpful website to take a look at as well when you get to that appeal process. So that's all I have. Thank you.
Well, terrific. Thank you. We are waiting to receive questions now from our attendees.
Yeah, I will say, Angie, that I think it's really savvy to know when your prior auth expires, because it's super hard for our office to keep track of it. And so it can be good for 6 months. It can be good for a year. It can be good for 3 months. And we get a lot of requests for prior authorizations, reauthorizations for medications that didn't work for a patient. And so it automatically comes back up and part of that Cover My Meds log is things that are generated for meds that patients are no longer taking. And so part of that sort through is like, oh, that was the alternative. You tried to check the box to get the medication that you wanted, but you don't want to actually prior auth it because the patient didn't respond to it. And that's all in the list of things that we have to take care of.
Wow.
So yeah, I think we advocate every time that we request a prior auth when we get the approval letter back telling the patient, put this in your phone, call me 2 weeks prior, send a portal message that says my prior auth is due, so we can stay on top of it. Because yeah, the litany of, I joke that medicine's the only people that use fax. Like everyone else has moved on.
Yeah. You know,
That's
questions coming in on the chat. I actually have one for the two of you. You know, just hearing you talk about the various issues and kind of, you know, getting that little glimpse of what goes on behind the scenes. Are these issues with prior authorization, are they getting better or worse, or have they just kind of stayed the same? Do you see any changes happening in the future that would benefit the patient? It's just, to me, it's so frustrating to, you know, have these medications there that are developed specifically for migraine. Like when this happened to me, you know, and I'm, you know, 6-7 months free of migraine, and I've never experienced that in my entire life. You know, I kind of felt like, and I'm going to be dating myself here a bit, I think the most exciting Christmas that I ever had was like 82 or 83, and I got my first boombox, and I got Michael Jackson's Thriller and Huey Lewis and the News Sports on cassette. And if I had unwrapped those and jumped up and down, and my parents had said, we're going to take those back, here's your little handheld radio. You get to use that for the next 6 months instead. What it felt
Good
like.
analogy.
You can't give me this and now take it away from me. Is this going to get any better for patients?
I mean, I like to say the blessing and the curse of having new meds is having this as a problem. So this is what comes with really expensive. So we have made progress, obviously. You know, many of us practiced for a decade with all old meds and generics and reformulating generics and trying to get creative. And, you know, I think Dr. Gelfand and I are of the generation that we really didn't practice when triptans were new and shiny. And so we kind of lived in this period of time where everything had a generic. And so we didn't fight these battles, and our colleagues in other specialties who were having, like, even within neurology, like MS and things like that, where they had a lot of other newer medications. I think that our practice is savvier in playing the game. Do I think the game's getting better? No, but I know what to say, and I know what the hoops are and what the barriers are, and how to, like, thread the needle to get what I want. I'm not sure. I think there are less barriers.
I would agree. I think it is absolutely wonderful to even be prescribing some of these treatments. So it's great that we have this problem in that regard. I have not gotten the sense, though, that over the last few years that this has been getting easier or that it's becoming a less common issue to try to go through denials and appeals and all of these sort of things. I guess each month there's more research that's published, and that's another set of articles that we could potentially bring to these peer-to-peer calls or send to insurance companies. And so with each piece of new research where we could say, well, actually, patients with this subgroup of patients or this people with this other headache disorder who have tried this treatment that's been studied for migraine also responded. Every time we get another paper, that is something else that we can try to use to advocate with. So from that standpoint, I think things are always moving forward because there's always more research being published. But I think to really change this, it's going to take huge advocacy and fundamental changes in regulations about how insurance companies decide what is and what isn't covered, because right now they hold a lot of control. They hold a highly disproportionate amount of control. And I think that clinicians and patients really deserve to have that control.
So we have a couple of questions in the chat. The first one is, are any resources or ways I'm not sure if they're talking about us as providers, get help from manufacturers for getting a drug through the prior authorization process?
So in reading this, so we don't, yeah, so the manufacturers or pharmaceutical companies will tell us where they are on formulary and when they have made a win with a certain PBM and say, now we are the preferred on X, Y, and Z. The one thing that I think is important to this line of question is, if you continue to use the copay, if you never request a prior authorization and just use the coupon, you actually, as a population, do a disservice, because the way that a medication gets on formulary is that you demonstrate demand. So by generating a prior auth from a large population of patients that are all served by one PBM, you show the PBM, all these people that are subscribed to your, benefits or whatnot want this med, and they're asking for it. And so that helps the manufacturer advocate and say, look at all the demand that we have. If you just use the pharma coupon, that never comes to the level where the PBM knows that anybody wants it. And so then when the company goes, you should cover our med, they're like, nobody's asking for that med. No one's prescribing it. And of course, those are the trenches are like, yes, we tried to get it. So just going through the process of requesting a PA and not trying to circumvent, because it can be easy to fill the coupon and just get the med for free and could do that until it doesn't work anymore. But generating the prior auth generates demand, which improves coverage of all the meds.
So the second question is kind of related to that, actually. It's what happens when the drug company decides it doesn't want to help supplement the price of its drug. For example, it drops the coupons for Aimovig or Jovi or something like that.
Yeah, the longer a med is on the market, the less support they'll have for it. Pharmaceutical companies, it's a business. And so they're trying to give you, when a med is brand new, give as much support to create demand, and then they're going to pull back and pull back. And so maybe it was 12 months of support the first year and then 6 months of support. Or if the med was denied, we were going to cover all the cost of it. And now if the med's denied, we're going to cover, you have a $50, for example, I know in our area, the Ajovi coupon card has gone up, where it was if it was denied, the patient was responsible for 50 and then 100. And right now it's 150. And we're finding that 150 is a breaking point. People are like, I can't afford this. And that's a problem. There's not a great workaround for that other than to, navigating, getting coverage through. And that's what it requires to really fight with the insurance company, not to rely on the pharma assistance.
Companies can only give those coupons for on-label use, so they can't give those coupons for off-label use, meaning that kids anyone under 18 can't use those, or anyone who has a headache disorder that's not the labeled indication. So I know they have their place, but certainly in the peds world, we almost never can benefit from something like that because it's almost always off-label use.
And they're only good for commercial insurance. If you have Medicare, Medicaid, or TRICARE, you cannot use the coupon programs. That is a government exclusion. So they are only good for private insurers, which is, I mean, I work, you know, in DC. We have a large military population, so that can be a big
Sure.
barrier.
Well,
You
I'd
know,
like to thank our panelists. Oh, did you have something else?
one thing that I would advise too is once that coupon is no longer available, if you're still struggling to take care of that copay, I would definitely just go ahead and apply for whatever financial assistance they might offer. I mean, if it were to happen to me, I seriously doubt that I would qualify for it, but I'm going to apply for it anyways because who knows? You know, I think it would be better to find out for sure that you don't than to leave that money on the table.
Sure. Well, I'd like to thank our panelists for their great presentations and sharing this evening, and for our attendees for attending. Have a good evening.
Thank you.